series of Prime, and we'll be having with us a research team and an expert team where we discuss the recent guidelines of cerebral venous thrombosis. So to introduce the expert team, we have Dr. Chitra Venkat. She's the head of Neurocritical Care and a banging personality and a mentor at Stanford University. Welcome, ma'am. It's a pleasure to have you here. And the next powerhouse is Dr. Ponnaya, who's heading the Neuroanesthesia Neurocritical Care Unit at Kaveri Hospital, Chennai. Welcome to you, sir. And on the research team, we have Dr. Mahendranath, who's an associate consultant at Sakra Hospital, Dr. Devi Prasad, we have Dr. Soumya from St. John's Medical College, and we have Dr. Sindhu from Kaveri Hospitals. So we are good to go. So when we talk about guidelines, it's always a lot of pages to read. So we thought we'll bring a clinical aspect on how to look at guidelines so that it improves our understanding and also the patient care. So since it's a powerhouse personality, that's why the cartoons of a bang. So when we talk about a patient coming to the emergency with a presentation of headache, so when should we suspect a CVT? Chitra ma'am, your opinion on that?
Sure. So in general, headache that is coming into the emergency room is sort of undifferentiated headache. So the things that I would watch out for, so 90% of, cerebral venous thrombosis is going to present with a headache. But in any time, like new onset of headache, for example, in a young person who has no history of migraines whatsoever, this is the first time they're having a headache, or, in a pregnant woman or postpartum woman coming in with a headache, with some associated features, perhaps of raised intracranial pressure, like, they're feeling nauseous, their headache is worse, for example, when they are lying down, they have nausea and vomiting, or they have focal neurological signs. So these will trigger us to think that this is not a run-of-the-mill headache, such as migraine, and that we need to do some sort of imaging for them. And typically we start off with like a CT scan, off the brain to look for subarachnoid hemorrhage. And on non-contrast CT scans, you can find in some instances a hyperdense transverse sinus or a hyperdense straight sinus or internal cerebral veins or the superior sagittal sinus. So in general, I would say there's no specific feature that says that screams at us, this is the headache because of cerebral venous thrombosis, but in the right patient setting, new onset of headache. And in the ER, we generally say if you're above 50 and you're coming in with a new headache, that is somebody we need to image. Somebody who's postpartum, who is in the third trimester, who's on oral contraceptives, who's also a smoker, who's obese, just a new headache. We say this is not a garden variety of headache.
Ponnaya sir, anything you want to add to that from an intensivist point of view?
Yeah, so when a patient comes with headache, generally my approach is I don't think anything. Okay. So just the next step would be to do a CT scan. It could be anything. It could be a subarachnoid hemorrhage. It could be it could be an ICH. It could be anything. So just we do a CT scan and clear cut in the CT scan, in the plain CT, non-contrast CT, subarachnoid hemorrhage, ICH, everything will come. And if there is an ICH, then if the pattern is suggestive of a CVT, then we go for a vascular imaging. And if it is not, if there is no hemorrhage, then there are some evidence to indicate that there are evidences of CVT. Then we go for further imaging to confirm the diagnosis of CVT. So I think that we will discuss in the next step. But this is how our approach is, because in a neurological emergency, without imaging, we can't move further forward. So my my dictum to all my ER physicians are that is, you identify a neurological emergency, shift the patient to CT scan, check the ER checklist. So that's how it works here. Yeah.
Okay, sir. Thank you very much. And if we look at the guidelines on the clinical presentation, so it's in line with what all of us clinically practice. So a new onset headache, which is like fits the right patient. Like ma'am had pointed out, a younger patient, a pregnant patient. So that's what the guidelines also describe on what clinical features to look at. And also next thing we need to see is, what is the anatomical location, because that also dictates what your presentation is going to be, whether it's a sagittal sinus or a isolated cortical vein. So focal neurological deficits are more common with cortical veins. So that's what the guideline says. Moving on to the risk factors. So what patients, Dr. Chitra, ma'am, for you, the question is, what risk factors do you look at when you're trying to assess these patients and work them up clinically?
You mean if we have identified a cerebral venous thrombosis, what sort of risk factors we
Yes.
look for? So again, it's sort of a broad category. So one is, if we think about the patient population in which we tend to see CVT. Now, obviously, the distribution of patients is different in, India, for example, where my understanding is there's a lot of pure perial postpartum CVT. We see that here too, but probably not as much as in, for example, in a tropical country. Here, we tend to see a lot of hypercoagulable disorders. So somebody who has a prior history of venous thromboembolism, so let's say a pulmonary embolism or a DVT, or who has an identified hypercoagulable disorder, such as, antiphospholipid antibody syndrome. So we think about it. The second category is those who are on things that increase thrombophilia, such as hormonal contraceptives, typically something that contains estrogen, so an estrogen progesterone or an estrogen only. That, when you combine with a smoker and who's obese, that increases the risk of having a venous thromboembolism in any part of the body. So even the DVT or PE or CVT, quite high. The second category is malignancy, is a big one here, especially, I would say, sort of in the older age group. In general, adenocarcinomas, for example, whether it's the lung or the breast or another part of the body, when you have adenocarcinomas, that tends to increase the coagulability and cause venous thromboembolism, again, PE, DVT, CVT, etc. The third is like local, infection, so mastoiditis or sinusitis, dental issues, something that's around the venous sinuses, so you have infection. Adjacent to that, then you have septic thrombophlebitis, which of course can cause cerebral venous thrombosis. Finally, I would say are the neurosurgical procedures or post-neurosurgical procedures. So these are sort of the big category to think about as hypercoagulable states, such as pregnancy, postpartum, hormonal contraceptives, malignancy, inherited disorders of coagulation, infections, trauma. So these would be, sort of the things that we would look for and work up as we are progressing to treat the CVT.
Punya, so the question to you is, other than hormonal contraceptive, other medications which we use, and what has your experience been with the COVID vaccine CVTs?
During the COVID times, we saw a lot of videos. Like what Dr. Chitra said, most of our patients also fit into that same category. Many young patients, postpartum patients on OC pills. Even we get young guys, and sometimes with dehydration or some precipitating factors. Later on, when we come to the workup of thrombophilia, and when those turned out to be positive, and those patients, especially when they are dehydrated and when they got exerted, so those are such patients that usually we get. Most of our population which we get for CVT are very young or middle-aged, and almost the whatever the risk factors which has been described in literature do exist here.
The other category I probably should have touched on is like medications. So besides the contraceptives, here we tend to see chemotherapy-associated thrombophilia as well. So some of the cancer chemotherapy agents, and I would say the vaccine-induced thrombocytopenia and VITT also fits into sort of this medication category. Once we started recognizing that, the vaccination really switched over to the mRNA, and I'm sure we'll be talking about that a bit later.
So moving on to a very important component of diagnosis. So should CT be done or an MRI be done for the diagnosis of so clinically, Punya sir, like how do you decide which one to go with?
Like I told you in the beginning, so when we suspect a neurological emergency, our protocol is to do a CT scan. So in the CT scan, when we rule out the clear-cut things of ICH, SAH, or a major stroke or an infarct, then if there is a suspicion of CVT, our protocol is to go for an MR-based imaging. So we do a plain MR and a MR venogram, and if still the MR venogram is negative, then we go for a contrast based MR venogram, and that's supposed to be highly sensitive. And if the patient is so unstable or the patient is very sick, sometimes they can present with massive hemorrhages. They are intubated and they are in core brain situation. In those cases, sometimes we do CT venogram as well. So that is the practical protocol what we do follow.
Now I asked the research team to present on how the guidelines has been for this year.
The algorithm when you select CVT is radiological imaging is a very fundamental for the diagnosis only. That is because the specific signs are not there in CVT for presentation. The first important thing we have to do is CT, as you said, and thereafter CT is not always conclusive. Further imaging is better with CT venogram and MR venogram. The sensitivity and specificity of MR venogram and CT venogram is almost close to 100%, which is very reliable in confirmation of the diagnosis of the CVT. When do we do DSA is when we have planned an endovascular procedure. Along with it, we require to do a DSA. Otherwise, there is no requirement to do a DSA. MRV and CTV is enough to provide us with the diagnosis. Looking at the specific signs, looking at the first CT scan, the most important thing is a non-enhanced CT is the initial imaging we have to do, which will give us a clue to the diagnosis. The classical feature that we see in the CVT is a hyperattenuation of the affected venous sinus. The hyperattenuation is nothing but the occluded cortical vein. It has various signs that is called as a cord sign also. So moving to the next one. In CVT, there are other signs that can be present also. They are the cord sign, and there is a hemorrhage that has been present. The other hyperattenuation of the transverse sinus can be seen. In the image C, we can see it in the straight sinus, and in the deep venous system also, the attenuation is seen, or the suprasagittal sinus, where you can see a cord-like attenuation is present. The other clue that gives you is the multiple focal hemorrhages that have been present along the slide. So another important thing about the CT venogram is CT venogram is a contrast enhanced helical CT where you give a contrast in a time phased pattern, you obtain a venogram. It gives you a good anatomical picture of both the superficial as well as the deep venous system. In this image, we can see is a non-contrast CT where you saw an hyperattenuation. Doing a venogram gave us a confirmation that there is a filling defect present, and this results in the confirmation of the presence of CVT. What does MRI do in this? MRI is also a very sensitive modality of imaging. The MRI features is like the thrombus ages in CT. It similarly ages even in the MRI. And you have various findings like your thalamus being hyperintense, there is filling defect in your straight sinus here, and as well as flare hyperintensity is present along this. So bilateral flare hyperintensities also gives you a clue. And doing an MRI along with the other features like a phase contrast or using an MRV TOF sequence, we are able to find out the filling defects. So these are the features in MRI. So another thing is the MR venogram. MR venogram, how do we obtain? There are techniques of non-contrast enhanced MRV. Here, the advantage is that you don't have to give a contrast. Using a sequence called time of flight and phase contrast MRV, we can get 3D projections of the venous system of both superficial as well as deep venous system. This is based on a flow-related enhancement. We see the flow dynamics. It's sensitive to the flow contrast and no contrast is needed, which is an advantage when a patient has a systemic complications as like a CKD, where we cannot give so much of contrast. This is an added advantage. But the disadvantage is that it can result in a false negative study when there is a slow flow. So this can be confirmed. This can be advantage by giving a contrast when the clinical situation demands. So according to the present guidelines, the recommendations are the conventional CT or MRI is the first test in patient with a non-specific acute presentation. MRV is the recommended non-invasive study of cerebral venous system, always to confirm the diagnosis. CTV is a reasonable alternative in centers with limited resources and pretest probability is low. Suppose if the patient has a ferromagnetic devices like a pacemaker, where you cannot do an immediate investigation to take for an MRI, CT would be an alternative. It is quick, rapid acquisition is possible. And contrast enhanced MRV, gradient recall echo, like the special sequences in MRI using an SWI, GRE techniques, MRV techniques, they improve the diagnosis of cortical vein thrombosis and prevents us doing a catheter angiography to confirm the diagnosis. With this, we move on.
Chitra ma'am, what's been your experience on what is your go-to investigations when you're suspecting a CVT patient?
So as Dr. Ponea mentioned earlier, and as has been discussed, the first is like looking at a non-contrast CT for telltale signs, and those were beautifully presented, just now. When you see hypodensity on this non-contrast CT that doesn't, for example, respect the arterial territory, so it crosses, for example, from the PCA to the MCA territory, or the MCA to the ACA territory, we start thinking about, sinus thrombosis. Or you have the cord sign, or you have, hyper density in the transverse sinus. The next study, because these patients are coming in with headache and with sort of neurological signs and symptoms, maybe focal symptoms, maybe seizures, and there's a concern for some vascular problem. Oftentimes at my center, they get what is called a stroke protocol CT, which is a CT angiogram. It's not specific for the venous space, so it's a CT angiogram and a CT perfusion. And then on the CTA, if we look at the veins, you could kind of pick it up, and then we end up sending patients again for a CT venogram if the suspicion is high. If they haven't gotten, a stroke protocol CT, then we would send for a CT venogram as the first step, unless there's a contraindication, such as what was mentioned, is they have, acute kidney injury or chronic kidney disease. They are not on dialysis, so I can't dialyze out the contrast, for example. In that case, we do an MRI and an MR venogram. So we have, something called an MRI intracerebral hemorrhage protocol, which has all of these sequences, so we don't have to pick and choose which one to use. And on those, especially for isolated cortical vein thrombosis, MRI is extraordinarily helpful. Also, it helps us to kind of date the thrombus because of the changes that happen in the hemoglobin as it's breaking down from oxy to methemoglobin. So it helps us to date the thrombus. And then on SWI and on time of flight, MRV, we can look at which of the venous sinuses are obstructed, how the flow is, and how extensive it is. So DSA, we very, very rarely go to a DSA. So pretty much it's like CT venogram followed by an MR venogram. Oftentimes patients are getting both of them.
Okay, now that diagnosis has been done, the most important step is now starting anticoagulation therapy. So now the question is, does anticoagulation therapy really improve outcomes in patients with acute CVT? So the research team, Dr. Sindhu.
Sorry, okay, the initiation of anticoagulation definitely improves the neurological outcome of the patients without any doubt. There is a high level of evidence on that. So now the question is, what do we initiate it with? So the treatment of cerebral venous thrombosis is divided into three. One is the acute phase, the maintenance phase, and the secondary prophylaxis chronic phase. So the acute phase, we usually give low molecular weight heparin or unfractionated heparin. But it's going to be in the maintenance phase, whether we are going to give Novak or vitamin K antagonist, we'll ask the experts. But that is evidence which I will be telling later. Matani?
Um, Chitra ma'am, so what do you start with? Like, how do you do it?
So I think the question is, what would I like to start with and what has ended up starting? So, there has been sort of a paradigm shift, I would say, at my institution. I've always been a great proponent of using low molecular weight heparin for a variety of reasons. First, you don't have to keep titrating the dose. You don't have to keep checking, blood levels of like anti-factor 10A or heparin activity level or a PTT for it. It's a very standard weight-based, dosing, 1 milligram per kilogram twice a day. You can do it. The onset of action is also great. It's like 2 to 4 hours. It's in your system, and it achieves a very steady state level in about like 8 hours. So it's very convenient for patients. It's convenient for the nurses to use, and it has a very predictable onset and offset of action. It also doesn't bind to plasma proteins like unfractionated heparin does. And the incidence of heparin-induced thrombocytopenia, as you know, is also very low with low molecular weight heparin. So our preference is to start it with Lovenox, but when, let's say, a patient has an intracerebral hemorrhage secondary to, a venous hemorrhage, some people do get nervous about it. Or if they are going for a potential procedure such as, decompressive hemicraniectomy, which I'm sure we'll touch on later, or if there is some enthusiasm for taking them for a suction aspiration or thrombectomy, in those instances, we might use unfractionated heparin. But my preference, and I would say at this point of time, the last few years, finally, we've kind of moved over to using low molecular weight heparin as opposed to unfractionated heparin. Now, there are some instances, I have to say, where you can't use, low molecular weight heparin. That is, if somebody has, kidney injury, then or extreme obesity, which we tend to see here, like BMIs of like 40 or so. Those patients, we cannot use low molecular weight heparin. We have to use unfractionated heparin. But there is I would say, a spot for both of them. It depends on the patient type. Preference is low molecular weight heparin.
Dr. Chitra, if I can add, in some patients have thrombocytopenia on workup.
Mm-hmm.
So in those cases, what is your protocol? Do you use low molecular heparin or reduced dose low molecular heparin, or you prefer to use fondoparinox kind of drugs?
Right. So that's a great question. So the first, thing I would sit back and think is like, why is this patient having thrombocytopenia, right? So for example, if they have vaccine-induced thrombocytopenia, then that is similar to having, heparin-induced thrombocytopenia because of antibodies to the platelet factor 4. So in those instances, you want to use something that's not heparin, such as fondaparinol that you mentioned, or argatroban, for example. But it's almost, counterintuitive or rare to see thrombocytopenia in somebody who has cortical vein thrombosis unless they have an underlying condition such as vaccine-induced or other hematological issues. And in those instances, the preference is to use a non-heparin product like the ones that you mentioned.
So like you mentioned, the practice here as well is to go with low molecular heparin in the beginning. And what would be the dose which you use? It's 1 milligram per kg, or it's a different dose which you use for these patients?
It's 1 milligram per kilogram twice a day. That is typically the dose that we use. Some instances, or I would say some institutions, use a higher dose, which is 1.5 milligram per kilogram, but then that's once a day. So it's usually like 1 milligram per kilogram in divided doses. Yeah.
So in our experience, even if the patient goes for decompressive craniectomy in a later stage when there is a venous infarct and edema setting in, or the hemorrhage getting expanded, there is a Moss effect, midline shift. We have a good experience of reversing even the low molecular heparin with protamine transiently during surgery. And we have even demonstrated that with the thromboelastogram activity, that it has been reversed, and we hardly transfused in few of our cases where the patient went in for decompressive cranectomy. But in most of literature, it has been mentioned that when the patient is going for DC, it's better to use heparin. But as you rightly said, using heparin monitoring for the nurses, everybody, it becomes very cumbersome. And do you monitor the low molecular weight heparin activity, like with anti-factor 10A, anything?
Yeah, not usually, not usually. We might end up checking it maybe once to make sure it is in the therapeutic range, but we don't continuously monitor, let's say every day or twice a day, what the factor, activity level is. And the reason for that is because it has a very steady, like pharmacokinetic, very predictable, I shouldn't say steady, very predictable pharmacokinetics for low molecular weight heparin. But as you absolutely said, unfractionated heparin, it is a big hassle. So the original protocols where they use unfractionated heparin involves giving a bolus of unfractionated heparin followed by a drip, like we do for other venous thromboembolism like PE or DVT. But let's say somebody has a venous hemorrhage, everybody's going to get very nervous about giving them a bolus of unfractionated heparin and then starting and continuous infusion. The reason, for giving the bolus, as you all know, is it helps you to get to a steady state with PTT or heparin activity level much faster than if you just start them on a drip. So when we just start them, let's say on a drip 800 units, it's again, I think it's like 14 to 16 units or whatever per kilogram. It takes time to get up to therapeutic state. Number one, it takes, anywhere from 24 to 36 hours in our setting to get to a therapeutic, PTT level. And number two, some patients, there's actually probably about 15-20% of patients who are resistant to heparin. For them, what you find is you end up using extraordinary amounts of heparin, and it's because they are just resistant to unfractionated heparin. Because they might have, let's say, antithrombin 3 deficiency underlying. You need that for the heparin to work. So it's a messy drug, in my opinion, to use unfractionated heparin. So my preference would be to use a low molecular weight heparin for them.
Some of the patients do come to not the ER but to the outpatient department, and you find a CVT and they're so clinically stable, can be managed as outpatient also. So would you recommend starting directly on a NOVAC in such cases, or have you used such practices? Because there are some studies which shows that we can directly start NOVACs rather than an acute therapy with a parenteral heparin or low molecular heparin.
Yeah, great question. So I don't see these patients in the outpatient setting coming with CVT. Typically, they are showing up in the ER or they're getting transferred from the hospital. But the question you're asking is a very good one. You're basically saying the patient looks otherwise really well. Let's say they have a very small, sinus thrombosis of transverse sinus, but they have a good transverse sinus on the other side. They have good flow in the sigmoid, for example. Why do we even need to admit them to the hospital? Can we just send them home? So the first thing I would say is, to make sure that they have good follow-up. In our setting, sometimes we just lose patients to follow-up. So having a good follow-up is important because we also face legal consequences here, if you let patients go without, continuous monitoring and supervision. As far as starting a direct oral anticoagulant, I guess, pharmacokinetically speaking, you can, but there are very few to no randomized control trials that have done that without a loading period of heparin. So a loading period is generally somewhere between like 2 to 4 days of heparin. And when I say heparin, it means all heparin, either unfractionated or low molecular weight, and then transitioning them to DOAC. So we don't have great experience with starting them directly on DOAC, at least not in a big way. And as far as sort of, randomized controlled trials between Coumadin or warfarin and DOAC, there's pretty good equivalency amongst them. So it's a good question. I don't think we have very good evidence for doing that, at least in the setting that I practice here, and I certainly haven't heard any of our institutions here that follow that protocol of starting DOAC directly. So it's usually a heparin loading period of somewhere between 2 to 4 days, followed by a transition to a DOAC.
Duration.
Unmute, Matangi. Unmute your mic.
Dr. Sindhu, if you can tell us what the evidence is for the maintenance phase, what should we use? Should we use a vitamin K antagonist? Should we use a DOAC? How long should we
summarize the recommendations? So once a clinical suspicion for cortical vein thrombosis is made, or the cerebral vein thrombosis is made by the MRI, so once it is confirmed, then we have to initiate the parenteral anticoagulation, that is with low molecular weight heparin. If there are no contraindications, that is, if the kidney functions are normal, then you can go ahead with low molecular weight heparin. Otherwise, if the patient is going to undergo some surgical procedure or some interventional procedure like Chitra ma'am said, then you would have to initiate with unfractionated heparin. That's what the AHA guidelines say. And this lead-in period of heparin, according to the guidelines, is between 5 to 15 days. And there is no clear-cut guidelines whether it's going to be 15 days, 10 days, or 5 days. That depends upon the patient-to-patient basis. The clinician should take a judgment. And followed by the maintenance phase with the oral anticoagulation. And for that, we have two main agents. One is the novel oral anticoagulation, the NOACs, and the vitamin K antagonist, that is the warfarin or the coumarin. So there are many trials which have been done comparing the vitamin K antagonist and the NOACs. So they suggest that from the available evidence, it is suggesting that it is reasonable to transition to directly acting oral anticoagulation after a lead-in parenteral anticoagulation, whether it is 5 days to 15 days, which is a safer period. That depends upon the patient and the decision of the clinician. And there are a few trials which I would like to quote. One is the RESPECT CVT trial. Here they randomized 120 patients with CVT, 1:1 with warfarin and dabigatran. And they concluded that there was no significant differences in the venous thromboembolism episodes as well as major hemorrhages. So they found that dabigatran was equally efficacious to vitamin K antagonist. The second trial is a secret trial, and this compared rivaroxaban with low molecular weight heparin. And here also there were no particular safety concerns, and there were no clinically relevant major hemorrhages given. And of interest in this secret trial, there was no lead-in heparin period. That is, they did not give heparin. They directly started the patients on NOACs directly. And the next one is the ACTION CVT trial. Here they compared the vitamin K antagonist and the DOACs directly. And this was a large RCT. It comprises of 845 patients. And here also they found that there was no significant differences in the venous thromboembolism difference in recurrent venous thromboembolism between the two groups. So basically, they also have emphasized that DOACs are not suitable in patients who are pregnant and breastfeeding. So low molecular weight heparin is recommended in these patients, and also in patients who are positive for antiphospholipid antibody syndrome. These patients have increased incidence of thromboembolic episodes if DOACs are given. So in these particular patients, low molecular weight heparin should be preferred. So that's what they have suggested. And regarding the duration, so the duration of the maintenance phase is a minimum of 3 months for patients who have a known cause. That is a known predisposing factor. It could be just oral contraceptive pills or hormone replacement therapy or just a septic focus which was causing all this. But if the patient is having a non-modifiable risk factor, say for example, a cancer patient or thrombophilia profile is positive for them, then they might need the maintenance therapy to be prolonged 3 months to 12 months. And again, the neurologist or the clinician should be assessing that patient every time the patient comes, whether the anticoagulation can be stopped based upon the risk profile, whether the patient is able to tolerate the anticoagulation or whether the patient is going to bleed. So that risk benefit ratio should be taken into consideration, and they have to decide.
Okay, Chitra ma'am, the question to you is like, do you have any monitoring schema to understand when to continue, how long to continue anticoagulation?
Yeah, before I answer that, I would highly, encourage Dr. Punaya and your team to publish, using DOACs directly off the bat for patients with CVT without this lead-in period. There's very scant literature, out there other than this phase 2 study that you just mentioned at this time. So it would be lovely to see literature come out where in your practice setting you are moving towards this. That's how evidence gets built. But going back to your question, is how long or what sort of paradigm do we have to determine how long somebody needs to be on anticoagulation? So as you mentioned, at least 3 months. So most of the recanalization of the venous sinuses are going to happen, I'd say, within like 3 to 6 months. So after 6 months, it's, you might get a little bit of recanalization, but by that time, the clot has become like fibrotic. There's going to be very little recanalization at that point of time. So minimum, first 3 months, and those 3 months are basically to allow the body's like mechanism to sort of break down the clot, to prevent like propagation of the clot to another area. So that's why we have at least the first 3 months. When we are working up, why did this person get a CVT? We think of, do they have a reversible factor or do they have an irreversible factor? So reversible factor, like, let's say they were dehydrated. Now, it's unlikely that it's going to recur in the absence of an underlying, thrombophilia like antiphospholipid antibody syndrome. Let's say it's malignancy associated. If the malignancy is like treated, then it is a reversible factor. So we look to see if they have a reversible factor, and if they have a reversible factor, so for example, local infection like mastoiditis, they have septic thrombophlebitis, you're treating with like antibiotics, that's taken care of. If it is a reversible factor, then there's no need to continue it for, let's say 12 months. So typically what we do is we do interval imaging with, let's say, a CT venogram or an MR venogram. In general, we try to compare like apple to apple. So whatever they got in the acute phase, then we also do it in the 3-month period to look for recanalization. And if it's completely recanalized, there's really no need to continue it beyond 3 months. But let's say there's only been partial recanalization, then we would continue it for 6 months and would probably repeat, imaging at that point of time. If they have like an underlying reason for recurrent thromboembolism, then these are patients that are going to need to be on pretty much, lifelong, because that factor you can't really take out. So if they have antiphospholipid antibody syndrome, they are going to be on anticoagulation lifelong. So again, it depends on whether it's a reversible factor, if you've taken care of it, if it's like, let's say, oral contraceptive pills, you've taken that OCP out of the picture, then, a shorter course, 3 to 6 months is sufficient. If you're seeing some movement in terms of recanalization between 3 and 6 months, but at 6 months, it's still only partially recanalized, perhaps you could continue to 12 months. But if they have an ongoing need for anticoagulation, then I would say they're going to be on lifelong anticoagulation.
Next question comes on endovascular and surgical management. So when do we have to go to the next step of doing endovascular therapy? So I request Dr. Mahendra to present the evidence.
So the evidence and the guidelines suggest that we can't go for reperfusion therapies as a standard treatment. We have to consider it on case-to-case basis, and at present, endovascular procedures can be only used as a rescue treatment in a patient who is already fully anticoagulation is achieved. Despite that, if the patient is deteriorating, we can consider on case-to-case basis. And what does the guideline says? The AHA guidelines, which was recently released, suggests that there is no proper evidence to suggest it as a standard therapy, and it has to be considered as only a rescue treatment. Even the S2K guidelines, the German guidelines, says that it should be considered as an individual basis. And in 2018, the Society of Neurointerventional Surgery has released some guidelines where we can consider reperfusion therapies. In that, they have told that if there is a clinical deterioration despite the fully achieved anticoagulation, and if there is a progression of hemorrhage or venous infarction, and if the patient is comatose at the presentation, if there is a deep CVT or posterior fossa involvement, these are the clinical situations where we can consider reperfusion therapies, and where we can't give anticoagulation like thrombocytopenia, any bleeding disorders, in recent history of gastrointestinal hemorrhages. In these conditions, we can go for reperfusion therapies, and it has to be on case-to-case basis. And what is the evidence says? Until now, there are a lot of retrospective studies and case series are there. They are not conducted in a controlled manner. But whatever studies have done, the systemic reviews about those studies states that even though the recanalization was achieved almost more than 90%, there was no clinical benefit achieved. Only few case series has shows that there is a clinical betterment. And one RCT which is conducted until date is a 2-act trial. It was published in 2020, and it was a multi-center RCT, and it showed that there was no benefit of reperfusion therapies over standard treatment, and it was prematurely terminated because of high complication rate. Almost 10% of the patients in reperfusion group had a mortality when compared to standard treatment of 3%. So the current stand is it should be offered only as rescue treatment once the medically fully anticoagulation is achieved, if despite that if the patient is deteriorating. And there is no proper consensus or agreement regarding the which intervention should be offered and the safety and efficacy about any of the particular choice of the intervention.
Okay. So, Ponya sir, what's your experience been with regard to when to decide with decompressive craniectomy in CVT?
I think deciding on decompressive craniectomy is straightforward when the edema is extensive and the mass effect is there and the patient is clinically deteriorating, or there's a hemorrhage which causes mass effect and it's expanding. We go for decompressive craniectomy. The question here is, I've seen two group of surgeons. So one believe that after doing the duroplasty, we need to go inside and evacuate the hematoma. The others believe that it's better not to touch the hematoma at all. Even how angry the brain is, how tense the brain is, just do duroplasty and come out, because by touching the hematoma, because it's unlike an intracerebral hemorrhage, what we see, this is a venous infarct and hemorrhage. So the more and more you meddle with that, sometimes the post-operative CT, the hemorrhage will be even more extensive once we try to evacuate the hematoma. So this is the two dilemmas. Some senior surgeons believe that we need to get the clot out and you need to have that surgical skill to get the clot out. But I do see some surgeons when they try to intervene and then try to get the clot out, and we end up in a very, very, very bad looking CT post-operatively. However, the good thing is that however the CT looks bad, however clinically the patient is bad, they show very remarkable improvement, and the MRS grade which they recover after 3 months or 6 months is simply unbelievable. So that confidence we always give for the patient. However sick, however bad the CVT is, they have got a chance of good prognosis and good functional outcome.
The other important thing is special groups, which is very important in CVT.
I think just ask about that for Dr. Chitra also, as well as that practice, and what do they do?
Sure.
How do they make the prognosis?
Yeah. So let's start with the endovascular approach. So totally, we practice very similar to what the AHA guidelines have laid down. So the 2-act trial was, our interventionalists really looked to the 2-act trial to give some guidance about the use of endovascular reperfusion. You can use reperfusion. It's in a slightly different way. It's basically a clot extraction aspiration. For severe patients who kind of fit the 2-act criteria, but unfortunately that trial was a neutral trial. In fact, it showed a higher signal of harm in the endovascular group. So we are not super enthusiastic about taking patients to the endovascular suite unless they have quote unquote failed anticoagulant therapy. So let's say they have been on good therapeutic anticoagulation, either with unfractured heparin or low molecular weight heparin, and they're still continuing to have extension of their thrombosis, and they are running into complications because of extension of thrombosis, then in those instances, on a case-by-case basis, it is considered to go to the endovascular suite. So I've had extensive conversations with our endovascular folks, because we have seen like very similar complications, post endovascular with like really massive hemorrhage. So one of the thought is that, you're kind of like tugging and you're pulling and you're suctioning with these clots inside the dural sinuses, and it is not. It's a different procedure than just going in and extracting a clot out, which you do on the arterial side. This is much more of a heavy clot burden. It requires like multiple passes. And while you're doing that, you do end up, causing endothelial injury, which is part and parcel of the procedure. And then post that, you still have to start, unfractured heparin or low molecular weight heparin. And because of the endothelial injury, there's also increased predisposition to clotting. So all of this put together, it's not a go-to first pass therapy unless somebody is failing medical management. The second question was decompressive hemicraniectomy, and I completely echo what Dr. Ponea just said. Decompressive hemicraniectomy in this population is a very different beast than decompressive craniectomy for somebody who has a malignant MCA infarct. These patients actually do incredibly well with time. Some of the very early decompressive papers actually came out from India and Pakistan. The very first series of decompressive craniectomies for sinus thrombosis came out from the Indian subcontinent, showing that the outcomes after decompressive craniectomy are much better than the ones for ischemic stroke. Now, when do we go for the same indications? You have a big intracerebral hemorrhage, either like a big volume ICH, or you have like multifocal ICH with significant venous edema with like midline shift, they're coning down, they're herniating, they have raised ICP. In all of these instances, you have to release intracranial pressure, and so we go for decompressive craniectomy. As far as the question of whether to touch the clot or not to touch the clot, our surgeons typically go evacuate the clot if the pre-op CT shows like one single, mass of hemorrhage. Now, as Dr. Ponea said, this is very different disease pathology than having a spontaneous intracerebral hemorrhage. This is, with like venous venules kind of breaking down and leaking and causing hemorrhage. So usually it's kind of multifocal rather than like a single, big blob of hemorrhage. And when it's multifocal, you have to remember there's like islands of tissue in between those pockets of hemorrhage that just have edema. They have vasogenic edema, but they don't have any cytotoxic edema. Those cells aren't dead. And by trying to go in and intervene on those, you're going to cause more venous bleeding, and inadvertently, you're actually going to cause more tissue injury, setting these patients, recovery back. So the general rule is just go and do the decompressive craniectomy unless there's a very compelling reason to go touch the clot.
And
yeah, the next important thing is like we deal with a lot of special population when it comes to CVT, be it pediatric CVT or pregnant CVT or recently vaccine-induced CVTs and even traumatic CVTs. So if you can quickly say from a clinical point of view, how do these patients behave differently?
So I'll take a first stab at that. So for pediatric CVTs, almost, I would say, unless they have like local infection, almost always we end up finding some sort of underlying, thrombophilia. The way these kids present is very different than how adults are going to present. They present with like seizures and with headache and, different way than like an adult who might just come in with like a headache. So underlying reason for the CVT tends to be different in kids than in adults. And then for pregnant women, I'm not sure there's a unique way of them presenting other than to say the third trimester and the first 6, 8, maybe even up to, some people say up to 12 weeks. Postpartum is like a very high risk period of time. So any woman who comes back in with like severe headache, if we determine it's not due to like a spinal leak, for example, post epidural, then, this is going to be a workup for like CVT in these patients. And most of the time, they don't necessarily have another reason for having the CVT other than that they were pregnant, and pregnancy is sort of a hypercoagulable state, particularly the last trimester and postpartum. I'm sorry, what were the other populations that you had asked about?
Traumatic CVT. So that's a population where you might have a contusion on one side and a CVT on the other side. So how do we clinically determine the anticoagulation plan in this?
It's a very complicated, very tricky question. I don't think there is a right or wrong answer there. So if somebody has, let's say, an occipital bone fracture, and adjacent to the occipital bone fracture, then they end up having a transverse sinus or sigmoid sinus thrombosis. If they're asymptomatic from it, and if it's a small burden of clot, we generally don't even anticoagulate these patients. We monitor them, with interval imaging, but we don't end up anticoagulating them. If they have a traumatic contusion on the other side, and if we have assured that the traumatic contusion is not expanding, for example, which, as you know, it's going to blossom in the first, 4 or 6 hours, up to 24 hours. If that's not happening, then very, very, very cautiously, we start heparin on these patients. And in this particular subset, we almost always start with unfractionated heparin, then low molecular weight heparin. But if it's like an isolated fracture, there's no contusion, there's an incidentally found cerebral venous thrombosis, these are patients that I might not even choose to anticoagulate. So there's really no right or wrong answer here. It's very patient dependent on that.
And if I can ask Dr. Devi to give us the research evidence in this special set of population of pregnancy.
Okay, we'll deal with one after the other. So in pregnancy, two pertinent questions for women with a history of CVT. Does pregnancy increase the risk of recurrent CVT and other VTs? There have been different opinions among this, with the German and guidelines saying that there is scanty evidence to show or give a pertinent answer to this. But the AHA guidelines, which have come recently, they implicitly say that women with a history of VT appear to have increased risk of thrombotic events and in future pregnancies. And there was a study, systematic review consisting of 17 studies taking around 400 odd patients, and in which they have seen that the odds ratio of repeat or a recurrence of a CVT event is around 1.3 to 2.8 times. So, and they also saw a decreased rate of recurrence in the patients who were receiving any form of prophylactic anticoagulants. So, as per the available evidence, CVT per se is not a contraindication for future surgeries. And considering the additional risk factor that due to the hypercoagulativity state that ma'am referred to, the prophylaxis with LMWH should be considered in these patients. And the majority of the events which happened were in the third trimester and the first 6 weeks of delivery in the preparing period. So almost 80% of these VTs or CVTs happen in post delivery. So this is the area where we have to be very cautious. And what the guideline says is to continue the anticoagulant therapy for a period of minimum of 6 weeks. Depend and about the vaccine induced, the current COVID pandemic showed a lot of increase in the vaccine induced thrombocytopenia events, and the adenovirus based vaccines were the ones in which the incidence of CVT was very high in comparison to the mRNA vaccines. And in those cases, what the guidelines suggest is, in those cases where a suspected VITT is there, so laboratory testing for platelet 4 factor antibodies is recommended, because these adenovirus DNA cross reacts and there is a formation of autoantibodies against platelet factor 4. And despite the lack of evidence which are being there, given the similarity to autoimmune heparin-induced thrombocytopenia, avoidance of any heparin-based products is recommended, and intravenous immunoglobulin in the dose of 1 gram per kg body weight daily for 2 days, and administration of steroids have also been advised. Platelet and transfusion are not recommended per se, and non-heparin parental anticoagulants like an agatroban or fondaparinux are typically used first, and then we can transition on to an oral anticoagulant like DOACs once there is full platelet recovery. And in pediatric, majorly the incidence is more in that of neonates, and as ma'am said, the total presentation and the long-term effects are different in if there is a CVT in a neonate versus a CVT which has happened later on in life. And the long-term neurological sequelae may include anything like a developmental delay or sensory motor or visual deficits or a complex epilepsy syndrome. As far as traumatic EA is concerned, despite the presence of an intracranial hemorrhage, anticoagulation might be considered in traumatic CVT on a case-to-case basis. And there's very scarce literature at present to give a level of recommendation. And we have to keep on seeing for the neurological deterioration, and careful monitoring is crucial due to the increased bleeding risk. And current guidelines do not give any particular recommendation for this.
Ponya sir, I would like to request you to give the closing remarks, and then how you do it. Like if a patient comes with CVT, in a minute, if you can say what we need to do.
First thing is that recognizing the problem and the neuroimaging as quickly as possible. And the neuroimaging markers are pointing towards CVT, then get the additional imaging done, whether MR venogram or CT venogram or it is, confirm the diagnosis, and initiate anticoagulation ASAP, irrespective of whether the patient has got a hemorrhage or no hemorrhage, and monitor for the clinical and radiological deterioration. And in selected cases, when the patients deteriorate or edema is extensive or the patient's neurologically deteriorating, then go ahead with early decompressive craniectomy. And after the acute phase is over, follow up with NOVAC and reassure the patient family that however bad the patient is, the prognosis when compared with the other kind of stroke is it's better, and they do return back to normalcy in a few months' time. So this would be my message.
Chitra ma'am, if you have to give a message on clinical tidbits on what we need to look for.
I would say listen to what Dr. Ponea just said. But other than that, the two key things that I tell my trainees is first recognition. So this is a disease that is very easily underdiagnosed, and the diagnosis is made late, especially when it comes to the deep venous system. So it's very easy to ignore the deep venous system, let's say on a non-contrast CT, where you miss sort of the density in the straight sinus, for example, or if you have involvement of like the internal cerebral veins and you have some edema in one of the thalami, you're going to go along the tangent of working up for ischemic stroke or like maybe a tumor with, the thalamic edema. And so keeping this in mind and recognition is probably like number one. The second point I would say is, even if there is a bleed, even if there is a hemorrhage, it's a venous hemorrhage. It's not the same mechanism as having a spontaneous intracerebral hemorrhage. The venous hemorrhage is happening because these veins, the venules are very thin-walled and they cannot keep up with the pressure because the drainage system is blocked. So just like, I don't know if we have Drano there, but we have Drano to like open up all the clogged pipes here. So just you have to unclog the pipe. So to unclog the pipe, and to prevent like further, hemorrhage from happening, you have to immediately start them on anticoagulation, irrespective of whether there is hemorrhage or not. And the third, I would echo what Dr. Ponea just said is, watch for like deterioration, see how they're responding to treatment. And then if they need additional intervention in terms of their ICP is, really high, they are having, more cerebral edema, they're having more mass effective shift, take them for decompressive craniectomy, don't hesitate. and then if on a case-by-case basis to do endovascular interventions. So that is, sort of in a nutshell, is recognizing and starting anticoagulation right away, even if there is hemorrhage on the CT.
Thank you very much, ma'am. And on behalf of Classroom Series, I would like to thank you personally, Punya sir, and all the research team, which is Dr. Devi Prasad, Dr. Soumya, Dr. Mahendra Nath, Dr. Sindhu, for this comprehensive presentation. We wish to meet you in many more forums and decode the guidelines as and when it comes out. Thank you very much.
Thank you very much for inviting me. It was great to meet all of you virtually as well.
Thank you, ma'am.
Bye.